then with the creation of our own COVID centres as a direct point of contact, we think was actually a more beneficial route for Northern Ireland people.
Yes,
patients. Yeah,
it's going to come next to the COVID centres. But do you know how NHS 111 from Northern Ireland perspective was staffed?
There was supposed to be a specific section if you rung 111 and asked or indicated you were from Northern Ireland. It took you down a specific path as well because of the peculiarities and the differences within our healthcare service and structure in Northern Ireland.
Well, you said supposed to be. Was there not?
I think there were difficulties that were indicated at the beginning of the pandemic, and I think that's the utilisation of that service
Right.
in regards to that it wasn't as seamless or as efficient as we hoped it would be.
And were those difficulties ironed out?
Not to the extent that we thought that the COVID centres and our own telephone first services were actually a better solution to the problem.
Right, so effectively from 28th of February, Northern Ireland joined NHS 111, but then due to difficulties in the service, was it almost put into abeyance because the preference was to go to COVID centres?
Yep.
Okay. On reflection, was there been a better way to handle joining NHS 111, or would you just not join it at all in the event of a future?
I think in reflection we wouldn't probably join it at all, but actually go down our telephone first service, which is part of our no more silos strategy has been directed as to we actually had a 111 alternative specifically for Northern Ireland malaria.
Okay. I'm going to look now at general practice. There was a perception that the population of Northern Ireland couldn't get an appointment to see their GP. Do you think that perception is true?
I don't think it was accurate on all occasions as well. We did put out a number of messages, not just from the department, but also from GP committee and the BMA in regards to making sure that people who did need to access healthcare could. There was also an introduction in regards to telemedicine and again additional financial supports that the department provided to GP practices as well.
Yes. I think it's right, as the strategic framework from June 2020 sets out at paragraph 2.3, GP appointments have reduced by 19.4% compared to last year. Is that a statistic that you recognise? And
it's not a specific, but I do know there was concerns, but again, that was also offset in regards to those telephone and visual appointments as well.
Right, so any reduction in appointments was met by an increase in remote telephone appointments?
That was the intention, yes.
Well, it may have been the intention, but was a result?
I believe it was, yeah.
But does the department keep detailed statistics about how many GP appointments there are?
They didn't prior to the introduction of COVID, but they do now.
At what point in time did it come in?
I can't remember the exact date, but I'm sure malaria was in the evidence bundles in regards to when that was actually introduced, because it was, again, one of those measures that we find I think necessary and useful as well.
While we're dealing with telemedicine then, that was the telephone first consultation process you were talking about?
Yes, and also at GP level.
Yes. That wasn't a new concept, was it? That was a concept that had been considered in 2017. Is that correct?
I think it was initially looked at then, yes, as well, but I think due to the challenges of the pandemic, that I think it was something that was actually additional monies were put into so the GPs could actually put further resource into it as well.
Okay, because I want to compare the before and after. So the Royal College of GPs statement, paragraph 14, says the Department of Health in 2017 had encouraged practices in Northern Ireland to consider adopting a telephone first based triage system as a way to manage increasing demand. Only a small number of practices had taken this up. There were few practices using digital telephony and no digitally enabled triage systems in place. There was also no e-prescribing capacity in Northern Ireland, and this remains the status quo. So when Telephone First was brought in, were you actually starting, was Northern Ireland actually starting from a position where there was sufficient capacity to carry out telemedicine?
No, and that's why the department actually put the additional resource into that point. I think the initial tranche was in the region of £1.7 million in regards to that additional support specifically for that issue.
And at what point in time did you consider that there was sufficient capacity across primary care generally?
I would still be at an opinion, my lady, in regards that we don't have sufficient capacity still within general practice. And again, even when I returned as Minister in February 24, I did work to put additional supports into our general practice to make sure that we had the ability to make sure that what we wanted general practice to do was actually they were able to deliver it as well, because we still have challenges within our primary care and general practice.
Do you consider that telemedicine, the telephone first consultation process, is one of the success stories of the pandemic?
It is something that was actually, well, as you've indicated, it was initially identified as 2017. It was disappointing it took until the additional investments that were made in 2021 due to the pandemic that was actually the enabler to bring about that transformation.
Can I please have your statement on screen? It's INQ 000492281. That's at page 38, paragraph 103. Because, say, it may have been a success story in terms of the rollout of telemedicine to enable people to have telemedicine. Do you think that there was a sufficient consideration of equalities about the impact that moving to remote appointments in primary care would have?
I don't think there was the ability during the pandemic to take all that into consideration. I do think there is more work needs to be done in regards to that. The messaging at the time was if you still needed to see your GP, you should be able to get an in-person appointment as well. In regards to the additional supports to telemedicine, I do know that we provided additional resource to make sure that there was accessibility through British Sign Language and Irish Sign Language as well to anybody utilising the service.
Yes. Your statement says it wasn't possible to carry out equality impact assessments. I think we've seen in statements they tend to take about 12 weeks. Is that right? And tend to involve consultations?
Yes.
But it's right that there's a slightly lower level in terms of equality screening that can be carried about in terms of any policies that might be put in place. Is that right?
That's correct, yes.
And the equality screening doesn't have to take anywhere near 12 weeks. It's done on a form, generally by an official within the department, and then reviewed and countersigned?
Yep.
If we can please go to paragraph 105, where you say, I can't recall any specific mitigations for older patients, disabled patients, particularly those with sensory impairments, patients whose first language was not English, those with literacy issues, patients in areas with poor internet connectivity, patients who are homeless, and patients from lower socioeconomic groups. Are you saying that the Department of Health didn't consider the impact of a change in the mode of access to primary care for all those groups?
I am, yes, in regards to the specific introduction to the telemedicines. In regards to that, as I say, refer earlier to the enabling of the sign language, which was something that was already available through Health and Social Care and the department. So it is regrettable, but unfortunately, lady, that was the reality that we were facing.
You say it's a reality that you're facing. It's not a reality that you can't carry out equality screening on bringing in a policy such as telephone first.
In regards to the work that had been done in 2017 and the introduction to telemedicine, as I said, I think in the previous statement, there is more could have been done and more still could be done to make sure that we gain the full advantage of what is there.
In terms of more that could be done, has an assessment of the impact upon those groups been carried out since?
Not to my knowledge at this point and from the position I'm coming from.
Why not?
I don't know, my lady, and I'm not in a position to answer that. Whether the department can would be maybe inappropriate.
Is this another example of the department not looking at decisions with an equalities lens?
And from the evidence that's been put today and from the number of incidents that has been mentioned, my lady, I think, yes, that can be another issue that can be asked. And as I've said in previous answers, I think it's something the department could pick up on.
Okay. I'm going to move now to the primary care COVID-19 centres. So those were intended to provide services for those suspected of COVID-19, and the intention was that people with COVID-19 would go to those centres, and that would keep GP surgeries free for non-COVID conditions. Is that correct?
That's correct, yes.
Where did the idea come from?
It came from, I think, discussions within the department with GPs through the BMA and the Royal College Committee of GPs in Northern Ireland. And it was something we were able to deliver actually at pace. I think we were able to open the first centre towards the end of March 2020.
Did it work?
It did, yes. Well, sorry, in my interpretation and my take from it, my lady, yes, I think it did. I think we've seen up to 65,000 patients or people went directly to COVID centres rather than approaching GPs.
So that was the aim, wasn't it, to keep people out of GP surgeries and also to provide a pathway to hospitals, emergency departments. Is that correct?
That's correct, yes.
And so the department considers that that system achieved its aims?
Well, I'm not sure if the department does, but I do, my lady. I think it was one of those successes where I actually saw primary care department and trust coming together to deliver those at pace.
Okay. Going to move now to ambulances. So we've seen in some of the department's reviews of access to emergency care that it's actually not possible to compare, or it is possible, but it's not appropriate to compare ambulance response data before 12th of November 2019 with any data after that, because there was a change in the clinical response model. Is that correct?
That's correct from my understanding, yes.
And then there was another change actually in the 18th of October 2021 due to a slightly different way that the statistics were being recorded. Is that right?
As far as I'm aware, yes.
So the statistic that effectively people are left with is the percentage compliance of how Northern Ireland Ambulance Service, NIAS, met the targets that have been set for response times. That is a fair comparison. Yep. Yes. And the department statement sets out at paragraph 429 to 430 that between April 2020 and March 2022, the mean and 95th percentile targets for Category 1, so immediately life-threatening for a response to arrive at the scene, and Category 2, emergency calls which are potentially serious. So the mean and 95th percentile targets for both of those were not met during any month.
That would be my recollection as well, but I think the T1 responses would actually, where a vehicle is required to be in attendance, were met.
Yes.
My lady, the prices on our ambulance service in Northern Ireland are not specific due to the COVID inquiry. In fact, they're still a challenge in regards to what we're able to deliver and again against what we want to deliver.
You say that you approved significant additional funding over the period of the pandemic for NIAS, and then paragraph 94, you say you've asked officials as to whether there's information pertaining to whether those funds resulted in the expansion of 999 capacity, but I understand these figures are not held by the department. Is there a difficulty here that if the department is providing additional funding to an organisation such as NIAS in order to improve its services, if it then doesn't actually track whether that funding has achieved the aim?
Well, as the sponsoring authority and under value for money, I believe it should in regards to those. I think at the time of the writing of the statement I wasn't provided with that detail as to whether that had been applied.
So it may be that the department does have all information, but you weren't aware when you were writing the statement?
As far as I'm aware.
So when you were asked, for example, to provide funding for NIAS to improve its services, would you ever find out whether that funding had been considered to be effective?
Well, in regards to, I think actually the majority of the bids that come into NIAS were met during the COVID pandemic. Again, it was for additional hours, it was for PPE, it was for turnaround times, additional cleaning of ambulances to sure. I'm not sure what metric was then applied to make sure that money was actually utilised to the extent that it was meant to, and that's, I think, from that previous answer.
Okay. One subtopic for ambulances. At the executive meeting on the 8th of April 2020, there's a question about air ambulance suspended, and you replied, helicopter suspended, air ambulance plane available okay. Appreciate those notes are not notes that you took, they're not formal minutes. Was the air ambulance helicopter, as opposed to the plane, suspended at any point during the pandemic in Northern Ireland?
Not that I am aware of in regards to that specific, but again, you're referring to handwritten notes that only became evident and presented during the inquiry.
Okay. Because given the geography of Northern Ireland, it's a critically important service to maintain. Is that right?
It's a very valuable service, and I think it's saved many lives in regards to that.
Given that you don't remember that, I'm going to move on to a different topic to look at emergency departments. Why are the waits so long, emergency departments in Northern Ireland?
My lady, this isn't specifically due to COVID. Unfortunately, it's a challenge that has faced the health and social care in Northern Ireland through quite some period of time. I think why they are so long is actually due to the flow of patients through our entire hospital system. So it's not just moving patients from the emergency departments into available bed capacity within wards, but it's also the onward movement of people who are in wards, actually moving them back into community settings as well. So when I come back in as Minister in February 24, I put additional monies into social care to try and improve that flow through and actually that support of getting people out of hospital, so we can get people, if you can get them out of hospital, you can get them from ED into wards, and if that improves the flow throughout the entire system, because no part of our system in Northern Ireland, or indeed across health and social care, can be looked at in isolation in regards to the challenges.
Same problems we have in England, isn't it?
Yes, it would be, my lady.
But just to indicate the scale of the problem, I think it's right that the Northern Ireland Hospital Statistics Emergency Care from 2022 to 2023 recorded that between 2018-2019 and then 2022-2023, the number of patients spending longer than 12 hours in an emergency department increased from 25,326 to 106,990. So that's a fourfold increase.
Yeah.
Why aren't the times getting any better?
Because we haven't been able to sustain that investment or transformation in health that we've wanted to throughout that entire period of time. And again, my lady, it's down to the topics we've covered previously in regards to not having a functioning executive for 5 out of the last 8 years, having single non-recurrent budgets year on year since 2016. So the investment in health and social care, domiciliary care, hasn't been as robust as I think it should be. It's efforts and steps I took when I was there as Minister. Again, my lady, the difference being is the domiciliary care in Northern Ireland is part and responsibility of health and social care, not devolved to local authority.
Did COVID-19 break emergency care or just exacerbate an existing weakness?
I think it exacerbated the weakness that was already there. It added additional numbers as well. The intention as well being that our COVID centres would have diverted some of that pressure away as well. So in regards to the numbers of people who may have been presented to ED with COVID symptoms could actually went to a COVID centre instead. But definitely the COVID pandemic highlighted and exacerbated the weaknesses we have in health and social care across Northern Ireland, not just in ED, but across the entirety of our system by the additional pressures that were put on our health and social care staff as well.
I understand that you say that the primary way, maybe the only way to fix it, is investment. But what steps had you taken within the resources available to you, so absent any additional funding in 2020, 2021, 2022, to try and improve the waiting times within emergency departments?
Well, it is about the additional monies, as I say, my lady, the additional monies that were put into domiciliary care, so we could provide actually more packages, more hours to get the flow through hospital actually better, so we get more people out of wards and off beds, so that we could get them from ED in. There's the additional investments that were made in GPs as well, so that people could actually be seen at a GP rather than the need to go to the emergency departments as well. Because
it's right that 2 urgent care services, so Phone First, which I think is where you call an emergency department, or slightly lower, the minor injuries unit is the word I was groping for, and then urgent care centres that were introduced in late 2020 were aimed to assess patients' needs before arrival and ensure they receive the right care at the right time and in the right place outside emergency departments if appropriate. Has either service actually worked?
Well, the beginning to work, there's also the introduction of ambulatory units as well, where people could actually be taken to a specific speciality in regards to when they do present in EDs as well. It's about the whole package. It's not just simply about looking at EDs, as I keep referring to. We need to improve our domiciliary care packages and supports. We need to improve our flow through hospital. We need to get people actually seen quicker at the right point in the right time. And I think some of the steps that has been made in our transformation from our elective care strategy through the introduction of day care procedures unit, elective overnight centres, these are all things that, my lady, and honestly, if they had been introduced as part of Bengoa post 2017, would actually have made the introduction of red and green sites or the flow through our hospital systems in Northern Ireland actually in a better place coming into the pandemic rather than where we are now.
You're talking about this being part of the piece. It's about the whole system working. So just want to ask you about non-emergency departments, about what the department's done to effectively restart services in the pandemic. I think it's right, there's a headline comment from the elective care framework that was produced by the department in July 2021, which reports that in March 2019, it was reported that a person in Northern Ireland is at least 48 times as likely as a person in Wales to wait more than a year for care. This is despite Wales being the worst performer otherwise in the UK. That's something you recognise?
I think it's actually part of my opening statement for the elective care strategy. It was put just at that stage. My lady, could I say that was following on from an elective care strategy that was actually published in 2017 that was never built on or never enacted due to the fall of the executive.
And I think the 2020 regional service delivery model for day case elective talks about how that the fundamental reason why the current levels of waiting lists is because demand is increasing due to demographic change, and its demand for care is steadily outstripping the ability of the system to meet it. Prior to the pandemic, for how long had demand been outstripping the ability of the system to meet it?
I think for a number of years, in regards to that, possibly from 2016, 2017, if I recall the figures from my time in the department. As I say, when I went into the department and took on the role in January 20, the biggest challenge of that, or the two challenges at that stage, was industrial action and the state of our health service in regards to ever increasing waiting lists.
I think it's fair to say that the fundamental problem of demand outstripping and lack of investment wasn't something that was fixed during your time as Health Minister.
Not during the pandemic. Years as well, between January 20 through to when the executive actually fell, my lady, in February 22. Ministers were then retained in post up until October 22, without executive meetings, without access to being able to formalise or actually having a political decision in regards to budget. That was something that was brought in by direct rules. So did waiting lists get better during my tenure? No, but we were faced by a pandemic through that time as well, and then at that point the executive fell again in October 22.
Yes, it wasn't intended to be critical, that question. It was a factual statement that it hasn't resolved in your time as Health Minister.
No.
Is there anything more that you think that you could have done as Health Minister to improve the situation?
During the two periods that I was in, the first, as I say, the intention was about how we actually developed and delivered the recommendations from Bengoa. I think, Raphael, you've looked at, my lady, in regards to the transformation that we could have delivered and we should have actually been pre-delivered prior to 20. The pandemic that then set us off course in regards to how we reacted, how we were firefighting. That was already under pressure. Wasn't able to do that during that time, but I think coming towards the end, when we look to the development, as I say, the day case procedure units, the elective overnight centres, post-anaesthetic care units as well, there were those measures that were being taken, were being introduced, but again, and I know it's something that was said in the opening statements, do require that commitment of sustained recurrent funding to enable those transformational projects actually to continue.
The inquiry's looking at 4 non-COVID conditions: ischemic heart disease, hip replacement surgery, colorectal cancer, and inpatient mental health services for children and young people. Just putting aside the mental health services for 1 minute, in relation to ischemic heart disease, hip replacement surgery, and colorectal cancer, are the challenges faced in restoring those services to what I think you would consider an acceptable waiting list, do all of them have exactly the same answer?
They do, and I think it refers to but how we bring about that transformation to service, how we look to those specialised centres across Northern Ireland that currently is happening. I know that's something that my predator, my successor, is currently looking at, it, how we look to specialised centres that can do high number volumes of those specific procedures, surgeries, diagnostic tests, rather than looking to each trust possibly doing a few, so we can actually bring that about. And again, come back to our elective overnight centres or day case procedure unit. That's what those are all intended to do.
I'm very shortly going to look at some of those responses in 2020 and 2021. Just one point I want to ask you about is targets. We see throughout a number of the departmental statements and frameworks that have been produced, discussion about targets, so waiting list for no longer than 9 weeks and no patient waiting longer than 52 weeks. What's the point of those targets?
It is to set that challenge to those who deliver, those who support, those who call for investment in health and social care, actually to see what can be achieved, what we want to achieve. And I don't think by moving or removing those targets would actually improve the service, because I do believe anybody working in health and social care in Northern Ireland has a genuine desire to meet those targets.
So are they actually more to inform people outside the health service about the state of the health service rather than people inside it?
No, the balance for both in regards to people outside the service actually knowing what the health service targets are, and in regards to the supply of that information, it is something I believe is now available on a central website or a central database across all the trusts that's available to the general public as to what state or where the waiting list is in each specific specialisation in each trust area as well. One of the steps that my successor has taken, that people are able to move across trusts as well, should there be availability to do that. And we were looking at that, in regards to how we actually utilise the whole of the health estate across Northern Ireland, and that patients aren't simply restricted to the geographical trust that they live in.
And that comes about through an overarching strategy that's imposed by the department rather than leaving it to the individual trusts, is that right?
That's correct, yes.
And is that not something that could have been brought in at a much earlier stage rather than your successor looking at it now?
Well, no, there is the elective care strategy. I think you actually quoted in their section as well. There's a cancer strategy, there's a mental health strategy in regards to how we actually set about all those specific pieces of transformation. We also, I suppose, the department also employed GIRFT, getting it right first time assessments in regards to our orthopaedics, in regards to EDs, in regards to how we actually bring about those changes.
Okay. I want to look briefly at CAMS. So the Department of Health's statement on data, paragraph 53 says, during the relevant period, the department did not routinely collect data in relation to the number of young people referred for inpatient mental health services. How can there be an effective commission of services if you don't know how many people need them?
It's a weakness that was in the system, and I know it's something that I and my special advisor actually raised within the department on a number of times as well. You mentioned, I think there a moment or two ago, the mental health strategy. There actually is a target within the mental health strategy in regards to additional investment in regards to CAM services, because it was something that was identified by us as needing actually work done on. It was something that was discussed at the assembly level through the health committee as well. But
isn't it simpler than making sure that there's a strategy, a mental health strategy? Isn't it simply, doesn't the department need to know how many?
It does, yes. If that data wasn't be collected, and I do recall there was a specific that we did challenge.
Well, this says the department has overseen the introduction of the acute managed care network, which became operational in February 2022. Work is currently being taken forward by that network, which will, when complete, enable the department to undertake routine monitoring of the number of inpatient CAMS referrals. So that suggests that the department still doesn't hold that data, even though the network's been in place for 2 years.
Well, that would be my reading from that statement as well. But as I say, when the executive and the First Minister resigned in February 22, there was those additional pressures that we were putting on it. Again, it was something that we were specifically asking for within the department, was that additional investment and recognition of CAMS, because we know, or I knew it was an area where we're lacking it.
Is there a fundamental difficulty with the department being able to access the data that it needs, and it's taking multiple years in order to get that data?
I think there has been a general recognition that the number of databases and points of collection have been outstripped by the need of what is accessible and what is concurrent and what is needed by the department to formulate those responses. And I think, I hope, my lady, in regards to that is why the department invested so heavily in the introduction of Encompass so that we could have a single point or a single data system that will cover eventually all 5 trusts.
I want to look then briefly at the independent sector. You say in your statement that you expected 120 to 135 procedures would be carried out per week across a range of red flag and urgent cases. Could you define red flag cases for us, please?
Red flag is those cancer-specific medical cases that the GP has indicated they need urgent and timely assessment.
And you say that was a reduced number of procedures, but the best possible in the circumstances. So are you satisfied that no greater use could have been made of the independent sector to either provide additional capacity to carry out treatments or to support HSC in the actual provision of staff or beds to treat COVID?
From the questions that were made by, I think, between the trusts and the Health and Social Care Board actually contracting and contacting the independent providers in Northern Ireland, which we have a very small independent sector in Northern Ireland. I think it was in the region of 130 beds across the 3 providers, so it's not comparable to what was here in England or Wales or indeed Scotland. But from the feedback that I was getting from those department officials and from the Health and Social Care Board, I was being assured we were making best use of what was available.
When you say best use, do you mean maximum use?
Well, maximum use, yes. And I think there's also the concern, there's also the added challenge at that stage. Our independent sector in Northern Ireland didn't have critical care capacity either.
But again, it's about using the tools available to you as the health minister, even though they are the independent sector, but making sure you're using the maximum capacity across all sources of capacity. Is that right?
And that's correct. And my understanding is that's what the Health and Social Care Board and the Trust were doing.
I want to look now just briefly at 3 frameworks about rebuilding services. The first is June 2020, which was called the Rebuilding HSC Services Strategic Framework. What was that framework meant to achieve?
It was meant to show how the system was preparing to get back to the level of delivery that we had prior to the first wave.
And what was the role of the department?
Well, it was
restarting services.
Produce that framework, to produce overarching policy, and then to challenge the Health and Social Care Board and the Trust to deliver it.
So in this instance, isn't the policy we need to be rebuilding our services, and then it was over to trusts to decide how to implement that?
Yeah, but there was also that co-production and co-working with the Health and Social Care Board and the Trust actually to do that.
Did the department take a firm enough grip about making sure that there was a regional response to rebuilding services?
I think in regards to the challenge of the Health and Social Care Board, whose remit it would have been to challenge the Trust, I think that we were doing that challenge function, the establishment of the Regional Prioritisation Organisation Group in regards to the
that
measurement.
The prioritisation group came in January 2021.
Yep.
This is June 2020.
June 2020. Yeah, and again, there was that challenge there in regards to what each trust were delivering again, because those documents were public facing and publicly available.
Okay. Did that framework actually achieve its aims?
I think that framework was actually probably superseded by the second wave.
I want to look at one specific example under it. At paragraph 2.31, so page 14 of that framework, it says the downturn in red flag demand through April and into May means that all trusts outside of Belfast currently report that all patients who are suitable to be listed for surgery have a scheduled date, either locally or within the independent sector facilities secured by HSC. That was probably the best position that Northern Ireland had been in for years. Is that correct, about people having dates for cancer treatments?
It wasn't the best position in regards to the number of people who were probably coming forward for treatment or being identified for red flags in regards to that. The fact that at that point we were able to meet need doesn't mean to say that we were delivering the service that we should have been.
Yes, because that's where I want to go into next. So it's on the paper to the executive from the Department of Health on the 17th of December sets out there's been an increase in the number of patients on the 62-day cancer pathway. And then it sets out that at 1st of October 2020, 3,500 patients were waiting longer than 62 days compared to 1,500 or so on the 11th of March 2020, an increase of 125%. So is it the position that even though you'd managed to reach a point where need had been met, I think to use your weights, the demand completely outweighed the ability of the service to provide.
To look at those, I suppose maybe not to challenge looking at those two specific points in time as being absolutes. It was, I think, the overall demand prior to what was presenting prior to the pandemic, and when we saw the realistic demand of proper present or full presentations coming through GPs and EPs.
And again, I'm probably going to get the same answer, but was the way to actually address that the restructuring, the funding, the investment?
It is, and then I think, my lady, there's quite a number of the questions I could answer today is about funding and investment and recurrent budgets in regards to the health service and what it actually needs in Northern Ireland. But I was taking the direction of council at the start that shouldn't be the answer to everything today.
And again, is this the same position in relation to the regional service delivery model for day case elective in July 2020 that you put in place those? Sorry.
No, go on ahead.
That you put in place those centres to deliver. You handed them over to either the South Eastern Trust or the Belfast Trust, but actually there hasn't been the breakthrough in terms of waiting list reduction that you'd look for.
Well, there hasn't been the large-scale breakthrough in regards to overall reductions to a significant level, but it's also about the plateauing of the level of demand against what we can actually supply before the health service, as it currently is, starts to meet the need and actually start to eat into those waiting lists. But again, my lady, in respect to where the service currently is, I'm sure someone from the department could properly address those issues.
Okay. Was sufficient use made of elective hubs to ensure that diagnosis and or treatment for non-pandemic conditions could continue uninterrupted in a future pandemic?
I think the establishment, and again it was the call even from Royal College of Surgeons as well, about the establishment of red and green surgical hubs were of a benefit. I think prior to the pandemic that work hadn't been completed in Northern Ireland, but with the establishment of our day case procedure units or elective overnight centres, there is an ability now to designate those, should there be another pandemic, as actually those green pathways to service.
And then finally and briefly, the elective care framework of July 2021. The experts instructed to look at hip replacements gave evidence, and they said that the blueprint which recommended elective care, the recommendations were fairly non-specific, and I don't think were well adhered to. There certainly wasn't a financial incentive. There was a review in February 2022 by GIFT programme, which was initially an NHS England initiative that went to visit Northern Ireland and made a series of recommendations which were much more about having more focused central organisation of care for orthopaedic waiting patients. Do you agree with that assessment?
I would actually, GIRFT was commissioned by the department to come in and look at orthopaedics in regards to that robust challenge as to what was actually needed in regards to that. And I think one of the recommendations actually was even down to the management of who managed Musgrave Park in regards to what trust it should actually be held in. That was managed by Belfast Trust. And I think one of the GIRFT recommendations was that if the Musgrave Park facility didn't get up to the required number of procedures by a certain date, that it should be, the management of that site should be taken over by another entity or trust. So, you know, the GIRFT report, I think, was much more detailed and forensic in regards to what it was actually saying. But
was the outcome of that effectively about having a more focused central organisation of care?
Yes, in regards to the GIRFT report recommendations.
That seems to be a recurring theme. That's from GIRFT, that's from the military assessment about critical care, that there needs to be a greater grip taken to ensure that there's a regional approach. Do you accept that?
I do, and I think part of I suppose the restructuring and the moving of health and social care, the closure of the Health and Social Care Board into SPPG within the department should bring about that focus, because it's now in-house in regards from a departmental point of view in regards to where that challenge actually sits.
Okay. I'm going to move on to a different topic, and it's about paediatric pathology. Did you hear the evidence of Catherine Todd about the experiences with her son Ziggy when he was sent for the post-mortem?
I have, and my lady, in regards to in regards to that, I think it's not just in regards to the evidence that was given. My son was in Birmingham Hospital at 8 months old for his first open heart surgery. We actually met a couple from Lisburn in regards to the child who was over there for medical treatment. They passed away in regards, were actually left in a similar situation in regards to being able to bring the child home at that point as well. So again, my lady, I don't think I can underestimate the evidence that has been given from individuals in regards to what can be done, what should be done. In regards to the paediatric pathology, I think there is an opportunity actually where we could develop an all-island solution in regards to paediatric pathology. It's something we've actually been able to do through paediatric cardiology, and something that has worked very well. So there are solutions that are there, but the challenges that we currently face with not having that commission service in Northern Ireland, I think are the outworkings of stories like Siggy's.
Isn't it right that effectively that's been the situation since January 2019 when the paediatric pathologist retired?
That is correct, and we've been unable to recruit a paediatric pathologist for Northern Ireland. Unfortunately, some of those work streams, my lady, fall when there's no executive in place or push to do that, because the establishment of an all-island approach would be something that would require a ministerial decision, something I can assure you, my lady, that I was fully supportive of, I would be fully supportive of, and I know my successor is.
Can I move on to shielding? Department statement says by 25th of March 2020, letters were being issued to the clinically extremely vulnerable population by a combination of general practitioners and health and social care trusts. In practical terms, it required a number of weeks for all these letters to be issued. I believe when Ms Hargey gave evidence to Module 2C, she talked about it taking a couple of months, 2 months in additional, because of seeking to access 500 databases for each of the general practice surgeries, and that took the additional period of time. Could it have been shortened? When I say it, could the period of time to communicate to those who should shield that they needed a shield have been shortened?
Not with the functionality that we actually had at that point in time, and I think the exact figure was in the region of 370 different databases that actually had to be sometimes manually trawled across Northern Ireland actually to identify those who met the criteria that was necessary for shielding as well. And again, I think that's why the investment in Encompass is worthwhile at this point, but it also, rather than just stopping at the development of it, the access to it by the 5 trusts, that they should actually look at it, but going further into general practice or even community pharmacy.
Has anybody run a test on Encompass to see whether it will be able to actually deal with an issue such as notifying people who should shield?
Not that I'm aware of.
Sorry, I failed to catch the first part of your question, as did the stenographer.
Has a test been run to see whether Encompass can deal with an issue such as notifying people?
I'm not sure, but I know that as one of the selling points that was presented to me, that we would have a single system across Northern Ireland that would be accessible, but it does involve it being across all 5 trusts and accessible to a point of where that functionality can be actually introduced.
Do you know how many people in Northern Ireland were shielding?
I don't have a figure, no.
Do you think the department knew?
I do, in regards to the cumulative effect and the number of letters that they were asking to be issued.
Because a briefing paper on the 18th of June 2020 says there are more than 95,000 people who have been advised to shield, but the notes of the executive meeting on the 5th of January 2021 talks about up to 200,000. Does that jog your memory about how many people there may have been?
Well, if those figures were reported to the executive, yes.
Was there clarity about what support should be provided to people in Northern Ireland who were shielding?
Well, and again, that was the intention of the letters going out, rather than the reliance on electronic or access to websites or anything in regards, so that those specific individuals who required notification or received it, and I think there were a number of letters sent out during the pandemic.
But that support wasn't actually provided by the Department of Health, was it? It's
No, it
provided
was
by the Department for Communities.
Well, there was a cross-executive response in regards to that, and I know there was cross-working across a number of departments in regards to how that would be supported.
And then, I believe it was on the 18th of June, a briefing paper was put to you about pausing the shielding advice from the 31st of July. Is that correct?
That's correct.
Are you able to explain why the view was taken on the 18th of June that people should no longer shield from the 31st of July?
Well, I think it was due to the number of falling cases that we'd had. I also think there was around that time that we had 14 consecutive days with no deaths due to COVID, and it was also in response and to keeping in step with the rest of the United Kingdom, who were taking the same action at the same time.
Because I think you were publicly saying that you didn't want anyone to shield for 1 minute longer than necessary.
That's correct.
Are you satisfied that that's what happened?
I am, but again, I think that's why we issued the letters with that lead-in time as well, in regards to what was actually necessary. We had, my lady commissioned, through the Chief Medical Officer, commissioned the Patient Client Council in regards to doing an assessment of those who were shielding and the impact and the effect that it was actually having on them, and did they find it useful in regards to that. And I think there were concerns that were raised by that cohort of people in regards to what it actually meant to them, both physically but also mentally as well.
After the 31st of July, did you hear concerns from people who had been shielding that they didn't have sufficient support after that point?
There was concerns in regards to the supports that were then available, but as indicated, and this isn't meant as a derogation of anything we were doing, but it was the support mechanisms that were there through the Department of Communities and through the Department of Finance as financial supports, letters to employers and things like that as well.
Going to move to long COVID. It was known at the start of the pandemic that it was likely that there would be long-term effects caused by the virus. At the start of the pandemic, were you made aware of that potential impact?
It wasn't something that was brought to my attention at the beginning of the pandemic. We were very much a bit focused on those who were suffering from COVID, rather than there actually being a further condition in regards to long COVID, or indeed some of the other.
Because in summer 2020, you asked the CMO to establish a clinical working group to review the needs of those recovering from COVID-19, specifically following a hospital admission. What took you to make that request to the CMO?
It was actually through conversations being had at the executive, but also other indications from conversations. I think we met, the four health ministers met regularly for conversations just in regards to what was happening across, but there was a need there, and I think it was actually something that was brought up at an executive meeting as well in regards to what we could do, but also from correspondence and presentations that were being made to me as health minister.
So it wasn't as a result of there being any tracking from the department or the trusts about... As a result of that review by the clinical working group, the report recommended that disciplines working on post-COVID recovery should be incorporated into a one-stop clinic. And at that point in time, there was such a clinic within the Belfast Trust.
That's correct, yes.
And then I just want to look at the timeline, because in December 2020, you agreed with HSCB should be asked to develop plans for a multidisciplinary clinic as part of the management.
Yeah.
On the 9th of June, approved proposals, and that HSCB should be directed to commission the service. And then the service was actually launched on the 1st of November 2021. How did it take from when the report came back, presumably in around autumn 2020, until the 1st of November 2021, to actually put in place these services that you believe should be in place?
Well, that was the request I'd made to the Health and Social Care Board, who were the commissioning service in regards to that, as to how quickly and what they actually looked like as well, and that was in their remit to do that.
Is there anything more that you think that you could have done to bring those on stream earlier?
Well, I could have put additional pressures onto the Health and Social Care Board, but I think there's a functionality across the department as well to do that.
Just want to look finally then at lessons learned. So you're Health Minister from the 11th of January to 2020. to the 27th of October 2022, and then again February to May 2024. As far as you're concerned, has Health and Social Care, the Department of Health and yourself sought to learn all the lessons from the pandemic that it could?
I think we have, my lady, and I think that is part of the functionality of this inquiry in regards to the engagement that we're having, both CMO, CNO and myself, in regards to that. As being asked, have I learned all? There's those personal reflections in regards to the decisions I took when I was Health Minister, weigh heavily, my lady, in regards to the challenges that I face and still think about, in regards to even the lines of, not even the questions that were being raised today, but some of the questions that I raised myself in regards, what could have been done? Were those the right decisions? Were they timely in regards to what we knew then compared to what we know now? In regards to the responses from the department itself, I think that is one that the department would be best placed to answer, my lady, as I stepped out, as has been indicated, and I was put out of post on October 22 and then didn't get the opportunity to return to February 24.
Okay. Thank you, Mrs. Swann. My lady, no further questions?
Thank you very much. Ms Campbell, would you like to take us to the break?
Mr. Swann, good afternoon.
Afternoon.
I have 5 topics and about 20 minutes in which to ask you questions on behalf of the Northern Ireland COVID bereaved Families for Justice. Can we start, please, by revisiting a topic that you were asked about very briefly before lunch, and that is the issue of PPE. And you'll remember that Mr. Scott took you to a readout of a meeting on the 24th of March with the First Minister, Deputy First Minister, and I think the CMO and others. And that readout suggests that there had been something of a misperception about the problem with PPE, and perhaps it all was not as bad as it seemed. Is that, and you recall that document?
I recall the document, yes.
I want to then move forward in time by about 10 working days to the 3rd of April 2020. And can we look at a document, please, which is INQ 0000655719, and it's _ page 10. There we are. These will be familiar to you, not least from Module 2C, Mr. Swann. They're handwritten notes of executive meetings, and this one is on the 3rd of April. And I wonder if we can look at the passage in the middle of the page. It starts DFE, which I think is the Department for the Economy, and perhaps Mrs. Dodds, you can confirm if I'm right about that, and perhaps you don't know.
I honestly don't know, I'm afraid.
Okay, well,
it could be Department for Education.
Yeah, I did wonder. In any event, the query you can see is in relation to PPE. How is it distributed in Northern Ireland? Not available when nurses need. How do we get it to frontline staff? And the Department of Health seems to respond, there is enough for now, but it needs to get to the front line. And if we can scroll down the page, please, to the next section, where Mr. Pengelly is noted, and Mr. Pengelly at that stage was the Permanent Secretary to the Department of Health, isn't that right?
That's correct, yes.
It is an issue of concern, it notes. The paper circulated today, details of stock, tend to focus on central stock, but asking them to check supplies with trusts. The issue for the trust, it's a low-level operational issue. And you can see at the very bottom of the page that chief executives are being asked to address. Can we go to the next page, please? Because the question that I'm interested in comes in again from the DFE. And it seems to be at the top of the page, the first 2 entries from DFE and RP, please, if we can highlight those. The question seems to be, is there a mechanism for trusts to report back to the Department of Health re the level of PPE and distribution to facilities? And Mr. Pengelly replies, no specific mechanism for report to us. Ask CEO to fill in returns. Every location has its own supply control system. So the question really that we have, and focusing on the issue of that central element of control that you've been asked about on the part of the Department of Health, is it really the case that on the 3rd of April 2020, there was no specific mechanisms for Trust to communicate with the department in relation to the availability of PPE on the front line?
I think that specific point is in regards to the management of stock levels.
Yes.
If I take this document in regards to my understanding or my recall of that meeting was actually in regards to not the concerns of the front line, but what stocks were being held in regards to either each ward or each trust. That's my read and my recollection of that actual engagement. It wasn't the fact that concerns weren't being raised. As I mentioned, in regards to the evidence I gave to Mr. Scott was in regards to how I asked the CNO to establish that PPE hotline, so that any concerns that were raised or could be raised were actually coming directly in to the department.
But of course, you've got the PPE hotline, which allows an opportunity for frontline staff to email the trust or the department if there are problems. But how does the department ensure that there aren't problems if it doesn't have sight of what the stock levels are at trust level?
And I think that's why Mr. Pengelly there has asked CEOs to fill in actual returns, so that documentation was coming back. And again, I think in regards to that answer that I gave to Mr. Scott was that health and social care were so used of PPE being that item that was always there in regards to when it was needed, in regards to then the change and challenge as to actually distribution, supply chain, the just-in-time supply chains that actually presented the challenges to the distribution and the central management.
But can we focus for a moment, Mr. Swann, on what control that your department had over this? The Chief Medical Officer has told Her Ladyship in the course of this module that as of the 27th of January, and you'll, I suspect, be familiar with this, Health Gold had been established, and then you had the Gold, Silver and Bronze Command, the purpose of which was to ensure effective oversight and engagement from top-level Department of Health to frontline staff. And PPE, as we've already seen, is an issue that has been of increasing concern throughout March 2020. So why is it that by the 3rd of April 2020, you were asking CEOs to simply fill in returns without a direct mechanism of communication to the Department of Health?
And again, that's the statement of Mr. Pengelly at that point in regards that no direct mechanism had been established, and that's how the interim measure was being put in place through the CEO of each trust to fill in those returns, and then that was superseded by the establishment and responsibilities of what BSO was actually doing in regards to the overall management of PPEs.
Putting BSO to one side, did the Trust Chief Executives then in April 2020 get to the point of filling in returns for them to be analysed by the department?
I assume they must have, because it wasn't then, follow up in regards to that, whether they actually were filling it in or somebody on their behalf was filling it in and returning it to the department, because that's when that more centralised control in regards to the work that BSO was doing was actually started.
Well, what did you learn? If we focus on the issue that Mr. Pengelly was raising at this executive meeting, one of the things that he said was that there was essentially every location has its own supply control system. So firstly, do you know what he means by every location? Was it every hospital? Was it every trust?
From my understanding, it actually every location actually went down to, as I said in the previous answer, actually down to ward level in regards to how PPE was actually being managed or distributed at each location.
And did that change, so far as you know?
Yes.
And when did it change?
I'm not sure of an exact date, but that was the outworkings of the mechanisms that were then later put in place in regards to how stock was managed, stock was delivered, and it was actually ordered via BSO through that central organisation system.
Would you accept that there seems to have been a problem, certainly in March and April 2020, in terms of preparedness to understand what level of stock was available to frontline staff?
Yes.
And really the email address that you set up, and I think you had something in the region of 100 responses or emails, was of little comfort to staff if in fact they couldn't be assured that the stock was reaching the front lines.
But it was of comfort in regards to they had an ability to directly contact the department and the chief nursing officer in regards to issues in regards to supply, fit and best use, because I think when we looked at the breakdown of the responses that you speak to, there were a number of critical issues that were being able to address and again fed back to either the ward or the trust in regards to those queries that were asked.
I'll move on, and my next topic is the topic of DNA CPR. And again, you had been asked some questions about that by Mr. Scott. And I want to revisit that paragraph in your statement. It's 307, in which you refer to questions coming in from MLAs and your response making it clear that orders based on age or disability were discriminatory and unethical, and in which you state that the policy, media reports about a policy in Northern Ireland around DNA CPR were ill-founded. You understand, and I suspect you understood at the time that you were responding to those MLA questions, that there were increasing concerns amongst the bereaved and those who were yet to be bereaved at that point, that there had been a misuse of DNA CPR orders in Northern Ireland. You knew that, didn't you?
Not that there had been a misuse in regards to the specific, any specific instances. I don't think it.
My question was, you knew that there were concerns.
Oh yes, there were. I know there were concerns. Yes.
And you agree, don't you, that from your position as the Minister for Health, it's important not only to consider what a policy might be, but how that policy is in fact being implemented within a healthcare setting.
That's correct.
And you told us in your evidence that you were aware of the CQC report that emanated from England.
Yes.
And are we right that your understanding of that CQC report was that it also applied in the north?
Well, that they had looked at what had happened in Northern Ireland was my understanding as well.
Do you recall what gave you that understanding?
I think it was through the reading of preparation for this session.
Do you recall being aware of the CQC report and recommendations at the time when these issues were being raised by you,
I
with you?
don't recall those specifics at that point in time, no.
See, the CQC report had an interim report in autumn 2020 and a final report, I think, in March 2021, contemporaneous, in fact, to the MLA questions that you refer to in your statement. Is your evidence that you weren't aware, or you can't recall being aware of that report at that time?
I can't recall being brought to my attention in regards to that, as I said in referral to an earlier answer in regards to those written statements or those written responses to MLAs. There would have been a subsequent information pack that would have been provided by the officials. I don't recall the full content.
Well, then let's leave the CQC report to one side if you weren't aware of it when responding to those MLA questions. What assurances, in real practical terms, did your answer that orders based on age or disability would have been or were discriminatory and unethical? In what way was that meant to assure the population of Northern Ireland that their concerns about the misuse of DNA CPR were misplaced or needn't be as grave as they were?
Well, I think that was the intention of those answers in regards to the statements that were being made.
But how can you answer that, Mr. Swann, without having carried out an investigation into what was happening at the ground level, at the front line? Well,
again, come back to, the additional information that would have been in the back of those written questions and written responses, my lady. I think they were, I also, and I can't be specific in regards to the conversations that I had around the issue with the Chief Nursing Officer, again, in regards to the issue of that concern.
Well, given that those were concerns, and that we are at this point into 2021 and that the concerns were persisting, did your department consider that there should be an investigation carried out into those concerns about the inappropriate use of DNA CPRs?
I'm not sure if the department considered that or conducted that.
Do you think it should have?
I think now there is an opportunity actually to retrospectively do that in regards to the recommendations in the work of this inquiry.
Well, going back to the CQC report, do you think you should have been aware of the recommendations and the conclusions of that report when it came out in March 2021?
Yes, the final report, yes, but as I say, I'm not sure that it wasn't even mentioned in the briefing pack in regards to those written responses. I don't recall, nor have I seen them in the evidence bundle, nor, my lady, unfortunately, did I ask for them.
The CQC report has a number of recommendations, I think something in the region of 11 under 3 broad headings. including ensuring that healthcare and health and care professionals have not only the knowledge to make ethical decisions, but the skills necessary to have those sensitive and difficult conversations with patients and their loved ones. And particularly significantly for the Northern Ireland COVID bereaved, they recommend ensuring improved oversight and assurance of the use of DNA CPRs. Do you remember any work under your tenure as a Minister of Health that sought to implement those recommendations in Northern Ireland?
I think, my lady, in regards to that, that was the start of the work in regards to the advanced care planning, documentation and engagement piece that was conducted. I think I commissioned that towards October, possibly October 22, in regards to work. I don't remember the specific date, but again, it was the wider piece around advanced care planning that also would have covered and touched upon DNA CPRs.
And that was October 22. So I'm focusing in particular on the period throughout 2021 when these concerns were being raised directly with you, and the report was available to you from the CQC.
Well, there was work being completed, I think, by the Ethics Forum as well.
Well, moving on to my third topic, and it's end-of-life care, and it's related because I suspect you will be aware, Mr. Swann, that in addition to the concerns about the use of DNA CPR notices, there were similar concerns raised about decisions around end-of-life care, including concerns about the discredited Liverpool pathway, which I'm sure will be familiar to you, concerns about syringe drivers or particular drugs that were used that were believed or there were worries that they hastened death. The same questions really apply. Looking at policies that were in place in relation to that end-of-life care is insufficient if there is not knowledge of what in fact is happening in practice. Do you agree with that?
It would be if that was what was happening in Northern Ireland, and again, there was reassurances, I think, given by CMO and CNO in regards to that wasn't either the policy or practice in Northern Ireland.
Well, but in terms of investigation, is it right that no investigation was ordered or conducted during your tenure in relation to the concerns that had reached the Department of Health?
Not that I'm aware of.
And do you agree that there was, and indeed probably still is, an opportunity to have that level of investigation?
I would agree with that line of questioning, and I think, as I said to the earlier question as well.
My penultimate topic is the issue of aerosol infection, and you'll have followed, I'm sure, how the evidence in this module has unfolded before her ladyship. Do you recall when you first became aware that there was if we can put it, a disagreement between scientists about the route of transmission, be it primarily droplet or aerosol?
From recollection, I think it was around May.
May, which year?
2020.
May 2020.
Yeah.
So
from recollection, and say it's not something I have any documented evidence from, but if it is from a conversation in regards to.
And do you recall who that conversation may have been with?
It may have been with the CMO and the CSA.
The CMO's evidence to this inquiry was that there was nobody in Northern Ireland providing, if you like, any separate advice about routes of transmission, and that he was, to a significant extent, reliant on advice taken from the UK HSA, and he accepted that advice and sought to implement it. Was that your understanding of the position?
Yes.
Well, coming back to this conversation, if it is around May 2020, do you recall raising any concerns about the acceptance of that advice, given the disagreement between the scientists?
It was in regards to, I don't recall the specifics of the conversation, but there was those general conversations that were had with CMO and CSA in regards to different aspects of the pandemic.
And were those concerns or that conversation, was it revisited?
It's not that I don't recall in detail of that or when those conversations were had, but I do know there was discussions around that.
Well, we know that there was a representative from the Public Health Agency in Northern Ireland on the UK IPC cell, and we now know certainly about the concerns about the length of time the UK IPC cell took to acknowledge the risk from aerosol transmission and to change advice. Would you have expected that the individual from the PHA in Northern Ireland would have reported those concerns to you?
I would have expected, not maybe directly to me, but I would have expected them to have been reporting that conversation either through the PHA to CMO or CSA, yes.
And do you recall that happening?
I don't.
See, one issue for those we represent is that the answer from the CMO in relation to being heavily reliant on advice coming from sources in England suggests that in a future pandemic, Northern Ireland would be effectively powerless to prevent something like this happening again, because we don't have the capacity domestically to replicate what the UK HSA can do or does, and you're nodding in agreement with that. But one outworking of that is that from a Northern Irish perspective, there's a limited number of lessons that can be learned or changes that can be properly implemented to ensure that doesn't happen again.
Yeah, and I also, and I think it was M2C in regards to Northern Ireland actually having that position at the table should have been through that body or SAGE or anything else. We don't have, in regards to the size of the population, the size of the department or the size of public health agency, the ability to replicate all those bodies, and I think it's also part of the benefit that I see of being part of those wider discussions as well, but also the ability then to be able to challenge within those bodies as well.
So, reflecting on lessons learned from your position or from the position of the department, what can be done to ensure a greater level of scrutiny from a Northern Irish perspective rather than acceptance of advice that's coming our way?
Well, in regards to that, I think it is that operational functionality of CMO and CSA in regards to the involvement and how those decisions are being made and the question of what can be done. I'm also aware, my lady, that the executive office within what is now used to be the office of the First and Deputy First Minister have now employed their own CSA as well, so that they're not solely reliant on the CSA within the Department of Health for advice as well. So there is, I suppose, a secondary. I don't know the full remit of that position, whether it can look across health or not, because, as again, unfortunately, I'm no longer in that position.
Final topic, and it's the topic of nosocomial infection. In your statement, it's at paragraph 233, you identify the creation of the nosocomial support cell to address challenges arising from COVID infections in healthcare settings. And you refer to a report of that cell in relation to Craigavon Area Hospital. And one of the positives, if you like, that you take out from your statement is that the reports from the nosocomial support cell were a timely source of feedback for our trusts on their approach and in relation to mitigating the impact of COVID-19 within the acute hospital sector. You're aware, are you, of the content of the Craigavon Area Hospital report from the nosocomial cell?
So, yes, from what limited recall I have and access bundles as
Would you have known about it at the time?
I do recall having engagements with both the Trust Chief Executive and the Board Chair in regards to the challenges that were being specifically faced there as well. There was also an SAI instigated, a level 3 SAI at that stage, and I asked that the findings of that SAI be made public.
Yes.
Something which isn't normal, my lady, in regards to that, but such, I think, was the concerns in regards to the actual outworkings of what had happened and what had occurred.
Well, one of the issues that the report found in relation to Craigavon Hospital was that effectively, although staff were doing their best, the problems were so significant due to the lack of ventilation on the site that they were almost, if you like, insolvable. So they found that there was no mechanical ventilation in the wards. They relied totally on natural ventilation from opening windows. They raised the problems with that approach during the winter months. They refer to the recommended air change rate of being unachievable. They talk about the proximity of beds, the lack of sanitary facilities combined with poor ventilation mechanisms. And they say it is difficult to see what more the Trust can do with the physical environment, given the constraints of the existing layout and fabric of that hospital. in essence, their recommendation was that the department should consider the Trust Master Plan for Redevelopment, which was apparently a programme that was going to take, quote, several decades. Firstly, from the perspective of patients and visitors concerned about the risks of going to hospital and contracting COVID, would they or should they have felt safe attending that hospital had they known those findings?
Well, again, those findings came as a result of the investigation that was commissioned in regards to the concerns that were being raised, and unfortunately the incidents of that occurred.
But do you accept that patients and their visitors essentially were not safe in that environment, or certainly didn't have any reason to feel safe?
Well, in regards to the mechanisms and the supports that were being put in place in regards to provision of PPE and other measures that were in place, I think the Trust and the staff involved were doing all that they could within the resource that they had. In regards to the investment of the site, and specifically around Craigavon, my lady, that is one of the sites that has been indicated for quite a long term in regards to capital investment.
Keep your voice up.
Capital investment and redevelopment, and I think that's the key finding of those recommendations.
Well, it very much was. And therefore my question was, do you know if the Department of Health has approved that master plan of redevelopment? And if so, how soon it's going to be implemented? I
haven't been in position now for a number of months in regards to the financial constraints that are currently on both revenue and capital. I'm unsure as to where that is, but I'm sure, my lady, it's something the department could respond to the inquiry on.
In dealing with that report on the nosocomial cell, you talk about it being never too early to learn lessons. And your statement, at the end of your statement, does set out what lessons that you have identified with the benefit of hindsight. Your statement mentions two broad lessons. Firstly, issues around staffing, including insufficient staffing and the need for an agile workforce. And secondly, that the CMO at the time had too many roles. Those are the two issues that you identify in your statement. Is that all?
No, there's a number of other recommendations.
Yes.
My lady, in regards to the completion of that report that I've thought of, in regards to some of them have already been touched in the question about how we can look across the borders or across the island in regards to health and social care, something that we've been able to do with paediatric cardiology in regards to the issue that was raised, paediatric pathology, or indeed ECMO, which was looked at or hasn't been touched in regards to today's procedure. Again, an all-round response could be something that could be explored. The further development of our health and social care transformation projects, those elective overnight centres, the day case procedure centres, the further steps that we need to implement in regards to Bengoa. But again, that is, my lady, depending on long-term recurrent financing in regards to what we need to do in regards to that as well.
Well,
Been quite.
yes, my last question, my lady, and I do appreciate it. The list is clearly long and a lot longer than the two lessons learned that you identified in your statement. From the perspective of the Northern Ireland bereaved, can you see why they may have expected more from you in terms of lessons learned?
In regards to this specific module, there are more modules to come where I'd be able to make further recommendations in the outworkings of what is actually there, and in regards to what's actually in the statement as to in reflection and preparation for today, my lady, there are others.
Thank you.
Thank you, Ms Campbell. We'll take the break now. I'll return at 3:20, and then there's just under half an hour of questions left for you, Mr Swann.
Okay, my lady.
All rise. Mr Wagner, over that way, Mrs Swann.
Thank you. Good afternoon. My name is Adam Wagner and I ask questions on behalf of the Clinically Vulnerable Families Group. In December 2020, there was a report published by the Patient and Client Council, which reported the findings of a survey. And one of the things that it concluded was that those who had been advised to shield prioritised being kept informed with clear advice and guidance, along with being given the scientific rationale for that advice. Do you recall that report?
I do, yes.
Yeah. So once that report came out in December 2020 and it was known what those who were being advised to shield were saying, by that point, it was obviously clear that the virus was continuing to circulate in the community, and for the long term, you were in the middle of the second wave. Do you think at that stage more could have been done to equip people who are at higher risk with that information they needed to empower them to understand the steps they could take to protect themselves, and also what support the government was giving them to do so?
And I do think when shielding was reintroduced in England in January of the following year, we wrote out again to those who have been indicated to shield in regards to the additional advice and guidance that we were able to provide them at that stage, because coming out of that PCC report, taken from what you've said, that's what they asked for, rather than the reintroduction of shielding. So that, I suppose, that additional communication that was given in January was I think what you're referring to.
And was it enough? Do you think people were given enough information to empower themselves?
I believe at that stage, as in regards to what we were known, and I think that, my lady, is one of the steps that by asking PCC to engage with those groups, I think that we in Northern Ireland were maybe better engaged with that cohort than perhaps other parts of the United Kingdom.
I want to ask you about pausing shielding in 2020 in June. When the plan was announced to pause shielding, you gave an announcement. You said, one of the things you said was the difficulties shielding has presented would not just vanish because the need to shield has ended. Do you think that the transitional support which was offered at that stage was enough to meet the scale of the challenge?
In retrospect, and again, it's working across different departments, could we have done more? There's always more we could have done in regards to, I suppose, allowing people to come back into society in regards after being through a very challenging time where they were shielding as well. And my lady, I remember, some of the conversations where we actually had with community pharmacy, who we supported to actually deliver medicines directly to those who were shielding. The feedback that they got from community pharmacy when those drivers were actually delivering those medicines, it wasn't just a matter of, here's your prescription, here's your medication, that they were actually being engaged in conversations because of the challenges that they were facing because of isolation and loneliness as well. So we looked into those additional supports as well. But again, if the question is, could we have done more, there's always more we could have done.
What about mental health support? There were, I think, mental health support resources were made available online. But do you think those were sufficiently tailored to the particular needs of those who had formerly shielded?
Well, the additional online ones, and again, my lady, there were also additionality and additional supports provided by community groups and other organisations. I was able to we put 10 million into a mental health support fund, which again supported communities and individuals across Northern Ireland, not only those who were specifically shielding as well, but also those who had received, had succumbed to those mental challenges due to the pandemic.
And when the shielding programme was paused, what was also ended was the automatic eligibility to statutory sick pay that people who had been shielding were receiving. And the practical effect was that some clinically extremely vulnerable people had no choice but to return to work because they couldn't afford to stay at home. You said in your announcement in June 2020 that shielding people could decide what to do at their own pace. Do you agree that because of the removal of the sort of sudden removal of statutory sick pay, the reality was for some shielding people, they couldn't return at their own pace. They had to return effectively straight away?
I do agree with that statement, although statutory sick pay not within the remit of myself at that point, or even the Department of Health, in response as to how long it could be paid for. I do recall engagements as well, and I think, and I can't be correct in regards to this, but there were opportunities for those individuals to engage directly either with their GP or their medical consultant in regards to receiving that letter of support, which would allow them to continue working from home.
Given at the time, June 2020, there was no vaccine yet, and also wider sort of society-wide mitigations, such as better ventilation, were still not in place, not really even in place today. Do you accept, looking back, that the effect of the pause was to expose some clinically extremely vulnerable people to high levels of risk, effectively a cliff edge from one day to the next?
In regards to, I think, the pausing of shielding, there was that, I think, a 3-week lead-in, from my recollection, from the announcement being made until that actual date being brought about. But that, again, come back to, I suppose, the original point that we were taking into cognizance the recommendations or the feelings that have been brought about by the PCC report and engagement.
Do you accept that after the shielding advice was paused, or the shielding programme was paused, it would have been valuable to continue to engage with those who had been formally advised to shield? Just to, for example, more ongoing PCC surveys or similar that would help you understand the impacts that the sudden pause of the shielding programme, even with that 3-week buffer, was causing, and also what support they would continue to need going forward.
Yeah. My lady, I do think there would have been value in further engagement via PCC, because their initial engagement was what basically allowed us to make the decisions that we did. And I think, as has already been intimated in the line of questioning, one of the strong recommendations was in regards to keeping those who were shielding better informed with reliable and up-to-date information.
Yeah, but so do you know why that wasn't done?
I don't know.
Should it have been done?
It could have been done, yes.
And do you think that might have fed into other concerns that the PCC report had identified, that the clinically vulnerable were forgotten or ignored as changes to guidance and restrictions for the wider population were announced?
Yeah, I think that ongoing engagement would certainly have addressed those issues as well. And again, my lady, I think that was the rationale for us actually engaging PCC at that stage, to have that direct interaction with that specific group of individuals. And I know it's something that didn't occur to the same extent or the same depth elsewhere across the United Kingdom.
Something else that you said when the shielding was paused was you asked for everyone to be everyone to be considerate as people end their periods of shielding. And you said, we should all continue to social distance, but in the coming weeks, I want you to be particularly understanding of the fact that you might be encountering someone who has had to stay at home for many months. Please be aware of this, show respect and kindness to all, and keep your distance. Now, at the time shielding was paused, and after that, and this is coming from a different direction, because it's not about information given to the shielded or former shielded, it's about information given to the rest of the public. Do you think enough was done to educate the general public about the ongoing risks posed by Covid-19 to the clinically extremely vulnerable and the clinically vulnerable?
And I think that was the basis of that statement in regards to showing that additional respect without identifying those who had been clinically extremely vulnerable and making them actually step outside society. It was about integrating them back into society after what had been a very challenging period during that period of time.
But aside from just saying that in that statement, was anything else done to educate the public about how to be respectful of and considerate towards the clinically extremely vulnerable?
It wasn't in regards to specifically the clinically extremely vulnerable. We did produce a keep your distance badge, which was a small yellow badge that we circulated around the general public in regards to that, just so people could identify. There was, the lanyards as well that some people wore just to identify, that allowed them to identify themselves as clinically extremely vulnerable, to encourage people to be that bit more respectful.
Yeah. Was anything else done apart from those badges and lanyards?
Not that I can think of at this point.
Do you accept that responsibility for educating the public falls ultimately on the government, and that there is a possible problem in placing the responsibility for explaining why ongoing mitigations are required? So, for example, wearing a mask without experiencing kickback and abuse from the public. Do you accept that if that burden of education is placed solely on or predominantly on the clinically vulnerable themselves, that can become unmanageable?
No, I would agree there is a job for government collectively in regards to how that communication is actually given out to the wider general public without making people uncomfortable in regards to them having to explain their condition continually.
I just want to ask you about DNA CPRs. You have been asked quite a lot about this, so I'll just ask you one question, and it relates to do not attempt resuscitation orders being placed on clinically vulnerable people. Is there any basis that you could reassure this inquiry that the clinically extremely vulnerable were not more likely to be the subject of a blanket DNA CPR on account of their underlying health conditions?
I'm unaware of it being a blanket approach in Northern Ireland, and I think I've given that to previous answers in regards to the same line of questioning.
Would you support a recommendation by the inquiry for there to be a systematic review of all DNA CPRs notices put in place from 2020 to date, so to get to the bottom of how many inappropriate notices there were, and also to make sure that clinically vulnerable people are not wrongly refused medical treatment in the future?
I know, in answer to, I think, Ms Campbell's questions from the Northern Ireland families, I think I have indicated that it would be something I would be supportive of, although not in the position, my lady, to actually take that directly back to the department.
Thank you. Thank you, Millie.
Thank you. Mr Sivakumaran, over at the back there. Could you make sure that your voice, because it does drop, you're softly spoken? Think if you're shouting in the House of Commons.
Thanks, my lady.
Good afternoon. I ask questions on behalf of the long COVID groups. My first topic is on pandemic planning and long-term sequelae. You said earlier that the risk of long-term sequelae was not something brought to your attention at the start of the pandemic. Professor Sir Michael McBride, the CMO of Northern Ireland, has said in evidence to this inquiry that he was aware of that risk. Just so we are clear, did he not advise you of that risk?
Not that I can recollect as a specific issue at that stage in the earlier stages of the pandemic.
Are you saying that you became aware at a later stage?
Yes.
Or what stage is that? Can you?
I can't give it a specific date, but in regards to the answers to Mr Scott, it was in regards, I think it was around June, July of that stage that I asked for the Health and Social Care Board to take forward the delivery of supports.
Now, Professor Sir Michael McBride's evidence was that the long-term impacts of COVID-19 were not tracked from an early stage in the pandemic, and he's added at present there's still no system to monitor long-term effects in a future pandemic, but he recommended that there should be. Would you also recommend that pandemic planning include provision for monitoring the long-term effects of a novel virus?
I would, yes. And again, my lady, I hope that, again, not building up the promises of what Encompass can or will deliver, I hope that that is something that it can actually do as well and doesn't resolve or resort to the Department of Health or Health and Social Care having to revert to the various databases that we had to previously.
Now, my next topic is about long COVID clinics. You were asked about the 18-month delay between your commissioning a working group on the long-term effects of COVID-19 and the establishment of a long COVID clinic in November 2021. The working group recommendations made clear that there was a need for specialist services which was not being met. Do you agree?
I agree, yes.
And it follows, doesn't it, that the delay in providing dedicated long COVID clinics in Northern Ireland left adults and children without access to the specialist care and support that they needed. Do you agree?
There was, I think as Mr Scott pointed out, there was clinics already established in the Belfast Trust, although not commissioned centrally across the rest of the region as well, and that's why I'd asked Health and Social Care Board to go forward and develop that as a commissioned model.
Indeed, so there was only one trust that had it. It was across Northern Ireland. There wasn't provision of the services that were needed for people with long COVID.
That's correct.
Now, you were asked what more you could have done to progress work on the clinic. You said you could have put additional pressure. Why didn't you put that additional pressure? Was there a lack of urgency in your mind in addressing the needs of people with long COVID?
I don't think it was a lack of urgency. I think it was in regards to what else was going on. I assumed that, and rightly or wrongly, that work was being progressed. And again, what I know now compared to what I knew then or what I was asking for then, there's recollections and reflections. As I said earlier, would I do things differently now? Yes.
Well, you were provided updates with advice. You were told exactly when the clinics were going to be established. Do you not accept that you knew then the delays in the provision of that service?
I don't recall those specific updates or dates in regards to a timeline.
Well, can you see why for people with long COVID who are struggling to get referrals to services or who are being bounced around from services, this delay was inexcusable?
Yes, and I've already said that in regards to how I wanted or should have now, in retrospect, been more vociferous in the delivery of those clinics across all trusts.
And can you provide any recommendations to the inquiry on how such an extreme delay in establishing necessary services could be avoided in future?
I think it is in regards to the changes, possibly in regards, as I said, my lady, the Health and Social Care Board was first indicated for closure in 2015. It wasn't until the legislation actually came about, I think in 2022, that it was closed. So the functionality of the Health and Social Care Board is now assumed in part of the Department of Health within SPPG. So there should be a greater focus and attention in regards to what that streams of work are actually being commissioned and delivered.
Okay, my final topic is about children and young people with long COVID. There are no dedicated long COVID clinics for children and young people in Northern Ireland. Professor Sir Michael McBride's evidence was he thought there was much merit to the suggestion by Professor Breitling and Professor Evans that a long COVID hub for children and young people could deliver care through virtual multidisciplinary teams. Would you agree with Professor Sir Michael McBride that there is merit to this suggestion?
I would, yes.
And would you agree that the failure to create a dedicated long COVID service for children and young people in Northern Ireland has left them without access to that specialist care that they need?
I do, but I also, in I suppose, reflection of what Sir Michael said in regards to following the NICE guidance at that point in time is what many and our clinicians in Northern Ireland actually did. I think that was where we were and where we took that advice and guidance from, was from NICE. But in regards to the recommendations coming from Sir Michael as Chief Medical Officer, I would be supportive of his approach.
Well, I just want to pick up this point about the NICE guidance. The NICE guidelines actually make clear, I believe at page 5 or under the overview, that the guidelines apply to make recommendations about the care in all healthcare settings for adults, children and young people. They also go on to provide advice at paragraph 5.8 that a practitioner should consider referral for 4 weeks for specialist advice for children with ongoing symptomatic COVID-19. So the NICE guidelines actually do recognise the need for specialist care for children and young people. Would you agree with that? There's nothing in the NICE guidelines to say there shouldn't be specialist
No, and
care.
that's why I'd be supportive of Sir Michael's recommendation in regards to that, also working, I suppose, in conjunction with the Royal College of Paediatricians.
So you accept that NICE guidelines do actually make provision for specialist services?
Yes, but not to the, I suppose, is how they are accessed and available in regards to what we deliver, what the Department of Health delivers in Northern Ireland. And that's why I say I would be supportive of Sir Michael's recommendations.
Just on that final point, when you say how they're accessed and available, then you agree that they're not accessible, specialist services are not accessible and available for children and young people in Northern Ireland because there's no specialist provision?
There is no specialist provision, yes, but as again, my lady, unfortunately, as I'm no longer in post as Minister of Health, it's not a lever I have direct access to, but if the Chief Medical Officer is coming forward in regards to those recommendations, I would be supportive as an individual and as a previous Health Minister.
Okay, thank you, my lady. Those are my questions.
Thank you. Ms. Poruchek, that way.
Thank you. Good afternoon. I ask questions on behalf of 13 pregnancy, baby and parenting organisations. You've already answered some questions about the visiting restrictions in general and the difficulties these caused patients and families, and a specific area of concern for women, pregnant people and their families were visiting restrictions in respect of pregnancy care in particular. Was the Northern Irish Government made aware of specific concerns raised by maternity staff in Northern Ireland about the availability and adequacy of appropriate PPE?
Yes, in regards to across the work that was being led by the Chief Nursing Officer, who had a Chief Midwifery Officer within part of her team as well, and I suppose cognizance, my lady, of the geographical and size of nature of health and social care in Northern Ireland.
And would you agree that alternative mitigations, such as PPE and testing, would have been reasonable steps to investigate, which might have avoided the particular harms which women, pregnant people and their families experienced from those visiting restrictions?
I think due to earlier comments in regards to reflections as to the availability of testing, if we had the ability to test at the beginning of the pandemic the way we had towards the end of the pandemic, I think we'd been able to do things a lot more different.
Okay. And just finally, were you also aware that some women and pregnant people delayed or avoided attending hospital due to concerns about catching or exposing their unborn baby to COVID-19 and the requirement to attend hospital alone? And if so, what steps did you or the government take to respond?
I wasn't aware of that being raised as a direct issue, my lady, but I do know midwives in Northern Ireland were using telephones to be in direct contact with those expectant mothers that were in their care as well. It's not an issue that was raised specifically with me.
Thank you. My lady, those are my questions.
Thank you, Ms. Polchak. Very grateful. I think that completes the questions for you, Mr. Swann. Thank you very much for your help today. It must have been a very long day for you, I'm sure. I'm not sure if I can say we won't be calling on you again, but I promise you we'll try to limit any burdens that we place upon witnesses like you we keep coming back to. So thank you for your help.
Thank you, my lady.
Thank you, Mr. Scott. Tomorrow at 10 o'clock.